Thank you, Carolyn, and ladies and gentlemen. Really a great pleasure to be here debating John Epstein on this topic. I thought the analogy was a little like taking on Albert Einstein on the subject of general relativity, you know, that he has really been such a giant in the field. But it's a genuine controversy there, and I'm going to make the case, which I truly believe, that we should not think of Gleason pattern 3 as cancer. And this is partly a kind of philosophical and semantic question. What does it mean to say that something is cancer? The hallmarks of cancer, lessons from histology, the natural history data, modeling, and finally the actual practical impact if we change our view of Gleason 3 and no longer refer to it as cancer. So it's a hot topic. This is just 3 publications in the last year or so that ask this question: should it be called cancer? Does it have those characteristics? And so, you know, part of this is, what do we mean by a disease? And this is the broader context of overdiagnosis, which is a malady of modern medicine, and this comes mainly from well-meaning attempts to identify diseases earlier, introduce treatment earlier. It's an unintended consequence of screening, and we are not alone in the prostate cancer field. And if you go through all of medicine, from psychiatry, oncology, general medicine, there are a whole slew of diseases where the definition of normal has been altered to include earlier patients, thinking that we will treat them and they will do better in the long run. And the result is, and these are just a few examples, diabetes, hypertension, et cetera, where by lowering the threshold for what is abnormal, you suddenly have, in American figures, hundreds and hundreds of millions of men and women who are now ill with a disease, or at least potentially diagnosed and treated. And it's very analogous to what we have in prostate cancer. And as a historical vignette, I have heard several times that Don Gleason originally did not think Gleason 3 or less should be called cancer, and he was overruled. John Epstein may have some insight into that. And then the definition of actually what does the word mean. This is from Dorland's 1994, a neoplastic disease, the natural course of which is fatal. The current version, a malignant cellular tumor, which is transformation into malignant cells, and malignant means a very dangerous or harmful in influence or effect, characterized by uncontrolled growth, cancerous, invasive, metastatic. So, you know, cancer is bad news. That's the message. Patients, of course, hear that, want something done. We, in the oncology field, lung, thyroid, breast, bladder, renal, small renal masses, many clinicians and there's many areas where we are struggling with this problem of what is really cancer, what's the natural history. So I think there are going to be some areas of agreement between Dr. Epstein and myself. Inter-observer variability in Gleason interpretation is high. Pathology is an art. One man's Gleason 3 is not necessarily another's. Between observer variability is in the 25% range. There's been great inflation. So the diagnosis of Gleason 7 since the 2005 redefinition by the ISUP resulted in one study from 25% of cancers being Gleason 7 to 65% almost overnight. So that's an issue. A third is that what you see histologically may not actually represent the molecular alterations in that cell, and there's clear evidence from some recent publications that prehistologic genetic characterization may occur. So Gleason 3 is just not one animal. Prostate cancer is obviously heterogeneous, but even one histologic pattern may be genetically heterogeneous. And there's exception to every rule. So even though I may convince some of you that by and large Gleason 3 does not behave like a cancer, there's going to be exceptions. And then the final kind of introductory point is that the Gleason scoring system has evolved over time. Now no one talks about Gleason 1 and 2 on the biopsy, at least. There was a shift upwards in 2005, and perhaps the next step is to redesignate Gleason 3 as not a malignancy. This is an incredible article for any of you who are interested. The update of the classic Heinahan and Weinberg article. This was in Cell a couple of years ago, the Hallmarks of Cancer. These are the original 6 ones. proliferative signaling, evading growth suppression, invasion metastasis, replicative immortality, inducing angiogenesis, resisting cell death. They've now added deregulating energetics, which is relevant to the earlier talk we heard, and avoiding immune destruction. So those are widely considered to be what defines the properties of a cancer cell. And what is remarkable is if you compare Gleason 3 and 4 to almost all of the molecular aberrations and genetic alterations that are known to be associated with these 6 or 8 behavioral characteristics of cancer cells, how for gene after gene after gene, whether proliferation, AKT, anti-growth signal and sensitivity, apoptosis, Gleason 3 tends to be normal. If it's a tumor suppressor gene, it's expressed rather than being absent in 4 and 5. If it's an oncogene, it's not upregulated, et cetera, et cetera. There really is a remarkable degree of consistency, mostly, with most genes that are known to be altered in cancer with 3 versus 4. Now, it's not 100%. There are some important exceptions that I'll show you in a minute. mTOR is one of them. TMPRSS2-ERG is often abnormal, but by and large, for most pathways, there's a world of difference between Gleason 3 and 4. Obviously, some heterogeneity exists. This is just historical. Stamey's famous paper, 1990, predicting metastasis. It was all percent Gleason 4. There were no 3s that metastasized in that early paper. And then we have from Hopkins, John's paper, 6,000 patients, RPs with pathologic Gleason 6, no Mets or prostate cancer mortality, 6,000 carefully characterized Gleason pattern 6. There's 2 other studies that have shown essentially exactly the same thing. This is a paper of 12,000 Gleason 6 treated with radical prostatectomy, obviously a major treatment effect, but they looked back at the proportion of these that metastasized or died of prostate cancer in the Gleason 6, 2 in 1,000 at 20 years. And according to the author, they've gone back and looked at those outliers, the 2 in 1,000, they all had elements of Gleason 4. So in fact, the conclusion of this paper was essentially no prostate cancer mortality from Gleason 6 with 20-year follow-up. Treated surgically, but this is the only way to get around the undergrading problem that bedevils the conservative management papers, where we know at least about 30% of patients diagnosed with Gleason 6 on a biopsy will harbor higher grade cancer. That's not the question. The question is, what does that Gleason 6 alone do? And then finally, the third paper I just want to touch on briefly, 14,000 cases of pathologically confirmed Gleason 6. There were only 22 who had positive lymph nodes. They went back and looked at those cases. They all had elements of Gleason 4. 14,000 cases, no lymph node metastasis, 0. What kind of a cancer is that? Pivot study, surgery versus watchful waiting, no benefit in low-grade cancer. You might expect some if there was some metastatic potential. It doesn't seem to be there. Now, this is just to help John make his case. This is one incredible paper, just came out, EPUB last week, from Hopkins Basic Research, Hafner et al. One patient who had a radical prostatectomy at age 47 and died 17 years later of metastatic prostate cancer, warm autopsy, whole genome sequencing of every metastasis and every single part of his prostate, and the molecular homology between the metastasis was to the microfocal Gleason 6 in one little part of his prostate, not from the Gleason 7 and 8 elsewhere in his prostate. So there it is. I don't know what you do with a case like that. You either say we know nothing about prostate cancer and microfocal Gleason 6 actually leads to all these metastases, or you say this is a really strange case and it's hard to be absolutely dogmatic. And also keep in mind this case was loaded with higher grade cancer elsewhere in the prostate. Maybe that microfocal 6 in a society of higher grade cancer has different molecular characteristics and phenotype than usual. This was a proposal by Mike Droller. It was published recently that said rather than this model of progression through PIN, Gleason 3 to 4 and 5 and higher disease with metastasis, a kind of bladder cancer type model with a bifurcated profile of either proliferative growth leading to Gleason 3, which is innocent, or dysplastic growth leading state to 4 or 5, with dotted lines here saying rarely you have progression. And we have some data that this does occur maybe around the rate of 1% per year, but is an uncommon phenomenon. I think it makes a lot of sense. You would not call this side a kind of malignant development. Finally, this is the cover of the consensus conference on active surveillance that was published about 1.5 years ago that concluded strong consideration should be given to modifying the anxiety-provoking term cancer for this condition. Proposals to call it idle tumors, indolent lesions of epithelial origin, or pun lump like bladder cancer, prostatic neoplasia of low malignant potential. And this would take a lot of the heat out of the patient's anxiety. What we call things makes a difference. I think one of the earlier speakers showed this similar thing. Both are cats, but calling it something different would reduce the anxiety of patients. We would think about it differently. It would make it a lot easier to counsel patients like we now do with PIN and ASAP with conservative management. And you do have to follow these patients. We're not saying it's completely normal, just that it doesn't behave like cancer and it shouldn't be treated like cancer. So to conclude, I think Gleason 3 occurs normally with age, lacks the molecular hallmarks of cancer, would be large societal and public health benefits to changing the nomenclature to a non-cancer term, understanding that there may be rare exceptions to this. Thank you.